Just want to welcome you to the next installment of the Anna Spowers Women's Brain Health Initiative Seminar Series, which is something that Dr. Kusieski and Jaren Toslow and Susan Gaudier and I have put together to really create a community for those that are working in the imaging space and kind of advanced computational techniques to have this watering hole to come together, to share ideas, and ideally to come up with new ways of collaborating. So I am so thrilled to introduce to you today Dr. Sheila Shanmugan. She's an assistant professor in the departments of psychiatry, OB/GYN, and radiology at University of Pennsylvania, where she directs, she's director of research at the Penn Center for Women's Behavioral Wellness. Dr. Shanmugan, who I had the pleasure of meeting so many moons ago, and it's just been such a pleasure to watch her star gone supernova. She is doing groundbreaking work that leverages multimodal neuroimaging and advanced computational methods to understand mechanisms underlying risk and resilience to psychiatric symptoms during all of the periods of hormonal fluctuation across the lifespan. So puberty, pregnancy, menopause. She's also a practicing reproductive psychiatrist with clinical expertise in perinatal psychiatric disorders, perimenopausal mood disorders and cognitive dysfunction, menopausal hormone therapy, and premenstrual dysphoric disorder. She just has this wealth of both clinical and research expertise. And really beyond the impact that she is making in the lab, she is fostering a growing community of physician scientists at Penn. In 2021, she founded Penn's Women's Mental Health Certificate Program so that psychiatry residents can obtain specialized training in reproductive psychiatry, really following in the footsteps and the path that Dr. Shanmugan has forged. So we are so...
Oh no. Is that me or is that everyone? I think everyone else is moving except for Emily. So, Sheila, I'm going to guess that she was about to introduce you and pass it over. So why don't you go ahead and do the slides? Emily, sorry, you froze for a second, just as you were about to turn it over, I think.
Oh,
So,
I'm so sorry.
no,
Well,
no, it's fine.
I was just like to say thank you so much for joining us.
No, thank you so much for that amazingly kind introduction, Emily. Can you all see my screen? And
Looks great. Yeah.
great. Okay, so thanks again for the opportunity to talk today. I am really excited to share a bit about the work that my lab does, particularly related to how we can use precision functional mapping to better understand perinatal depression and potential applications in reproductive psychiatry. So this is a brief outline of my talk. I'll start off with a clinical case that really highlights for me why there's this need to personalize early interventions in reproductive psychiatry and how this relates to how we approach patients who are at risk for perinatal depression. Then I'll give an overview of what personalized functional networks are and why it's important to think about them, as well as a brief overview of some of our recent results on sex differences in personalized networks. And after that, I'll talk about our ongoing work that uses precision functional mapping to chart personalized networks across pregnancy and the postpartum in women at risk of perinatal depression. And finally, I'll close with our vision of how we hope that this line of work will eventually impact how we treat perinatal depression in the clinic. So, as Emily mentioned, while I spend most of my time thinking about science and the brain and research, I'm also a reproductive psychiatrist, which means that I see patients with psychiatric symptoms that are in some way related to hormonal fluctuations or reproductive time points like pregnancy and menopause. And doing this really drives the types of questions that my lab tries to answer. So to give you an idea of what I mean by this, I want to start off by sharing an example of a clinical case that really drives home for me why there's this need to personalize early interventions in reproductive psychiatry. And this case is an example of a preconception counseling encounter, which makes up about a third of our practice and is where patients who are planning to conceive or become pregnant come in to talk about the plan for managing their symptoms or medications during pregnancy. So our patient is a 25-year-old female with no past pregnancies, no past significant past medical history, and comes to us for a new patient visit with a history of, quote, bipolar 2, but it's not really clear if she meets criteria for this diagnosis. She's been stable for about 6 years on Zoloft and Trileptal, which are both medications that target mood symptoms, and she's recently married and presents for preconception counseling. She wants at least 2 children, and she's planning to start trying to conceive next month. And she asks us if she should stop her medications during pregnancy. So how do we answer this question? So the main thing we do after we try to get more diagnostic clarity is consider the risks of continuing medications versus the risks of untreated psychiatric symptoms during pregnancy and the postpartum. So perinatal mental health disorders like depression, anxiety, bipolar disorder, they're among the most common complications of pregnancy and the postpartum. And these disorders impact more than 20% of individuals, and the prevalence has only been increasing in the last decade. And not only are these conditions highly prevalent, they also have really high rates of morbidity and mortality. And in fact, mental health conditions are the leading cause of maternal mortality across the US. And about 22% of pregnancy-related deaths are due to sequelae of these conditions, such as suicide or overdose. And of the mental health conditions that impact pregnant individuals, perinatal depression is one of the most common and impacts up to 1 in 5 women. So what am I talking about when I say perinatal depression? Well, the terminology is a little bit confusing because it's changed in recent years and different organizations use different terms. So until recently, we had mostly heard about postpartum depression, which is consistent with the DSM-4 terminology that defined this as a major depressive episode that started within 4 weeks after delivery. And since this specifically was after delivery, we sometimes hear about antenatal depression, which is depression that occurs during pregnancy. But then there was this increased recognition that symptoms start during pregnancy. And so in the DSM-5, the terminology was changed to major depressive disorder with peripartum onset, which refers to a depressive episode that starts during pregnancy or in the first 4 weeks after delivery. But this still doesn't really capture many other trajectories of symptoms. So the American College of Obstetrics and Gynecology defines perinatal depression as depression that occurs during pregnancy or in the year postpartum. And as with most things in women's health, perinatal depression has been historically understudied. So none of these terms really simultaneously capture the heterogeneity we see clinically. So I do anticipate that in the future, this terminology will continue to evolve and expand and become more specific as we learn more about what's going on. But for the purposes of this talk and our research, the type of perinatal depression that we're most interested in is new or worsening depressive symptoms during pregnancy or in the months following delivery. So symptoms of perinatal depression can include symptoms such as low mood, sleep issues, loss of interest in things you used to enjoy, feelings of worthlessness, and thoughts of suicide. And for individuals who experience depression during the perinatal period, the symptoms start during pregnancy in about 1/3 of individuals and start postpartum in about 40%. And rates of comorbidity are really high, with about 2/3 of individuals with perinatal depression also having a comorbid psychiatric disorder like anxiety. And while the timing of onset of these symptoms can vary, we know that overall the perinatal period is a time of heightened vulnerability to depressive symptoms, and that there are additional consequences of not treating symptoms adequately during the perinatal period, which impact both mom and baby. So just briefly, when we think about the consequences or risks of not treating or undertreating depressive symptoms during pregnancy, we think about risks to mom, risks to baby, and risks related to the pregnancy or obstetric risks. And so for depression, obstetric risks include hypertensive disorders of pregnancy, such as preeclampsia or gestational hypertension. Risks to mom include poor engagement with prenatal care, higher rates of relapse in those with comorbid substance use disorders, and sequelae of their underlying disorder like suicide. And we also know that untreated antenatal depression is a big risk factor for postpartum depression. And risks to baby include being small for gestational age, low birth weight, preterm delivery, low APGAR scores, and longer-term risks as well in the postpartum, including poor bonding and attachment, as well as increased risk of internalizing disorders later on, like anxiety and depression. But this risk calculation isn't the same for every patient. And inherent in this discussion of weighing the risks of medications versus the risks of untreated psychiatric symptoms is the question of, will this patient develop perinatal depression without medication? And sometimes this calculation is pretty clear. So, for example, if someone is on a medication like Zoloft with a lot of reproductive safety data that suggests it's safe to continue, and also has a psychiatric history that suggests they're pretty likely to decompensate, there isn't really much hesitation in continuing the medication. It's also sometimes clear in the other direction. For example, someone who was started on a medication after one episode of mild depressive symptoms that occurred in the setting of a pretty significant social stressor and has been stable for several years since with no significant risk factors, but a lot of protective factors. And in this case, where the chances of decompensating during pregnancy are pretty low, it's worth a trial off medication before trying to conceive to avoid a potentially unnecessary exposure, even if it's mostly benign. But sometimes this calculation isn't so clear-cut. So for example, going back to our patient, she's on 2 medications. Zoloft is considered pretty low risk, but trileptal has limited reproductive safety data and is structurally similar to a medication we would typically try to avoid in pregnancy. And in situations where there's a medication where we have a good reason to avoid it, we sometimes suggest delaying trying to conceive while we trial an alternate medication. But given this patient's age and her family plans, we're working with a compressed timeline because she may not want to delay trying to conceive. So ideally, we would want to know what are her chances of decompensating off medication and whether we would need to find an intervention with a better reproductive safety profile. But really, we can only guess at that type of information right now. So because we don't currently have the tools that would really optimize our medical decision-making, the questions we want to answer are, who will go on to develop perinatal depression, and what are the underlying mechanisms? And what we know from the existing literature about the mechanisms underlying perinatal depression is that they're really complex and multifactorial, and they're also not the same in every patient. So, for example, some women may be particularly sensitive to hormonal changes during the perinatal period, which involve this large increase in estradiol and progesterone across pregnancy, then that drop precipitously in the postpartum. There's also been increasing recognition for the role of neurosteroids like allopregnanolone, which is a GABA-A modulator. And one thing we think about a lot clinically is this shared hormonal sensitivity across the lifespan. So, for example, patients with menstrually related mood symptoms are often more likely to go on to develop perinatal depression. But it's not all just about hormones. Genetic and epigenetic factors also play a role, history of trauma, as do medical and obstetric factors, inflammation and stress, and then other factors that impact neurotransmitter functions, such as psychotropic medications and sleep. But it's only really recently that the field has started to think about how all of these factors interact with the structural and functional brain changes that happen during pregnancy and how pregnancy-related brain changes interact with psychiatric symptoms. And part of the reason for this is that until recently, we didn't really know how pregnancy was impacting the brain in humans. One of the first papers that really looked longitudinally at how pregnancy changes the brain came out in 2017 and did imaging before and after pregnancy. And it's only really been in the last couple of years or so that papers have started coming out where people are imaged during pregnancy. And what people have seen so far is pretty consistent, and it's that there are these widespread neuroanatomical changes across the perinatal period. Specifically, these studies have consistently found there are these decreases in gray matter during pregnancy, some of which reverse in the postpartum and some of which are really long-lasting. And the brain changes in these areas are thought to be necessary to facilitate behaviors needed in the postpartum, like bonding and attachment. But one thing that really stands out is that these changes, while they're pretty widespread, the areas that are impacted most frequently as exhibiting the greatest change relative to other regions, they overlap with the regions that have been implicated in depression and anxiety. So, for example, in this figure, these purple areas are areas that are impacted by both the perinatal period and depression. So to summarize where we're at right now, we know that pregnancy changes the brain. We know that pregnancy is a time of heightened vulnerability to depression. But what we don't know is who will go on to develop perinatal depression and what are the mechanisms underlying emergence of depression during the perinatal period. So to answer these questions, we're using functional magnetic resonance imaging, or fMRI. fMRI is basically an indirect measure of neural activity. And during a scan, subjects are lying down in a magnet, looking at a screen that either has a crosshair like this on it during rest or some sort of stimuli on it if they're doing a task. And while they're doing this, the neurons in the brain region involved in whatever they're doing are firing, which causes changes in blood flow and in turn the signal we measure with fMRI. And we turn that signal into these type of pictures that gives us an idea of what brain regions are involved in whatever they're doing in the scanner. So since they're just resting and looking at this crosshair, here we're measuring the signal in a bunch of different brain regions at rest. But we're not just interested in what a particular region is doing by itself. What we're really interested in is how brain regions work together as part of networks. And a brain network is basically a group of regions that function similarly and work together for a shared purpose. And you can think of these brain networks kind of like doctor's offices. So for example, let's say we have a patient who has diabetes. This pink network might be our patient's primary care team, and each member of that team, like the physician, the medical assistant, and nurse, are the pink circles, which represent individual brain regions in the network. And because they all perform aspects of primary care and interact with each other frequently to manage the patient's diabetes, they're all part of this primary care network. And our patient also has really bad knee pain, so their primary care doctor referred them to ortho, which is this blue network. Here, the team is made up of a surgeon, a nurse, and an x-ray tech who are all focused on treating the patient's knee pain. And our patient also has depression, so their PCP sent them to the psychiatry clinic, which is this other red network where they see a psychiatrist, a therapist, and a social worker who work together to treat the patient's depression. So the takeaway here is that regions that are doing similar things and work together with a common purpose are part of the same network. And I'll talk about how we actually define these networks in a bit, but the big idea is that regions that have similar fMRI signal belong to the same network. So over here, since the signal of these two regions look similar, they're part of the same network. But the signal here looks different, so this region belongs to a different network. And some studies have tried to look at whether various measures of how these networks function are disrupted in postpartum depression compared to healthy controls. So for example, they tried to look at how much brain regions in a given network interact with each other versus with brain regions in other networks. And this is just a schematic, but for example, these networks over here would be like more segregated and these over here would be less segregated. And the problem here is that these studies assume that everyone's networks look the same and are made up of the same brain regions, and that the interesting stuff is in how these brain regions interact with each other. But we now know that this assumption isn't necessarily true and that everyone's networks look a little different. So to illustrate why this is a problem, let's go back to our doctor's office analogy. So we have these three clinics and they're all in one building where primary care is on the first floor, ortho is on the second floor, and psychiatry is on the third. And we're interested in how often members of the same team communicate with each other versus with other specialties. The first step here is to define who is part of what team. And here we decide the way we're going to determine who is on what team is by physical location or what floor they work on. Okay, great, that works here. Then we want to compare the results to another health system. So we apply the same assumption that location is representative of function. In this system, the clinics are mostly set up the same way, except here they have medical students in their primary care clinic and no computers for them on the first floor. So those medical students use a computer room on the second floor. They're still part of the primary care team. They're working to treat our patient's diabetes, and they're not really doing anything ortho related. But if we assume that anyone who is working on the second floor is part of the ortho team, these primary care med students end up being classified as part of the ortho team. This makes it look like the primary care and ortho teams in this system communicate with each other way more than the primary care and ortho teams in this system, when in reality, their interactions are probably similar, but their landscapes look different. So before asking how these brain regions interact as part of networks, we need to define what brain regions belong to what networks. And this is really what a lot of our research in the past few years is focused on. So we now know that these brain networks look a little different in every person. For example, this pink network is generally in this area, but when you zoom in and look at what this network looks like at the individual level, you can see that it looks pretty different for everyone. And the term we use to this spatial distribution of a network on the brain is topography. And since these are functional networks, we refer to the spatial distribution of these networks as functional topography. Or in other words, which anatomic regions are part of a given functional network. So you especially see this type of variation between individuals when it comes to association networks. And you can think of association networks as these regions that are involved in cognitions, emotions, or social function, or whose regions integrate information flexibly. You can also think of association networks in contrast to networks involved only in sensation, perception, or action, like motor or sensory networks. So an example of an association network would be the ventral attention network, which reorients attention when a stimulus occurs unexpectedly. Another example of an association network is the default mode network, which is involved in internal and self-referential thinking. And the frontoparietal network is another association network that's key in executive functions, such as working memory. And in these association networks, you see more variation in the topography of these networks between individuals. And this is in contrast to sensory and motor networks, where the topography is more consistent between individuals. And multiple studies have come to the same conclusion, that there's more variation between individuals in association networks and less variation in these sensory and motor networks. So why do we think this personalized approach to functional topography is important for understanding perinatal depression? Well, traditional fMRI metrics have been really important in telling us about how the brain works on average across various populations, but they're pretty noisy and are not that reliable at the individual level, which is part of the reason why there's been such issues translating it to clinical practice. But the really cool thing about personalized networks is that they're both stable and reproducible at the individual level. And what I mean by that is if you put someone in the scanner one day and then you put that person in the scanner another day, if the scans are long enough and nothing major is changing, you can expect that those networks you're going to get are going to be pretty much the same because they reflect a person's intrinsic functional neuroanatomy. And that's a little bit simplified, but big idea is that these are much more stable and reliable than what we've been working with previously. And what's really exciting here is that there's more and more evidence coming out that personalized networks may also reflect important signal regarding cognition and psychopathology. So, for example, personalized networks have not only been tied to anxiety and depressive symptoms, but have also been important in predicting someone's future level of cognitive functioning. And there was also a paper that came out in Nature recently by Chuck Lynch and colleagues that showed that certain aspects of association networks indicative of psychopathology were actually present before the onset of depressive symptoms. We've also found reproducible sex differences in personalized network topography across adolescence. And some of the findings that we see suggest that the organizational effects of hormones may in part lead to sex differences in topography, which tells us that it's worth seeing if there are additional effects within females across pregnancy. And before diving into one of our current studies aimed at charting personalized networks across pregnancy, I want to take a slight detour and present some of our sex differences results to give you an idea of the way we define and analyze personalized networks. So in some of our previous work, we used precision functional mapping to examine sex differences in personalized networks in 693 youths and adolescents ages 8 to 23 years old who were imaged as part of the Philadelphia neurodevelopmental cohort. Here we defined personalized functional networks for each participant using a machine learning technique called non-negative matrix factorization. And the way this technique works is it first uses the fMRI signal for a group of subjects to come up with a probability map for the group. And this is an example of the group map for one network. And what it means is that for this network, each individual's network would fall somewhere in this red and yellow area, but can look pretty different for each person. So this step is important because it lets us compare subjects to one another, even though their individual networks within this area are different. So once it comes up with this group probability map, it uses this map and a subject's imaging data to get personalized networks for each subject. And using this method, each subject ends up with 17 personalized networks. And after defining personalized networks for each subject, we looked at the effect of sex on topography using a masked univariate approach where we ran a model to test the effect of sex at each vertex. And then we added up the effect of sex across all of the networks to get an idea of which regions show the largest sex differences. And in this image, areas in black are regions with the least sex differences, and regions in yellow are the ones that show the greatest sex differences. But we also want to know which networks contribute to this effect, which is what we see in this graph. So here on the y-axis, you have the number of brain regions that show a significant effect of sex. On the x-axis, you have each of the networks. And here I want you to focus on the right part of this graph. So each bar is a different network, and the color of the bar represents the type of network that it is. So red is the default mode network, pink is the ventral attention network, and yellow is the frontoparietal network. And here each bar represents the number of brain regions in that network that show a significant effect of sex. So higher the bars, more regions in that network that show sex differences. And this tells us that the networks that showed the greatest sex differences were association networks, including the default mode network, ventral attention network, and frontoparietal network. And in contrast, the networks that showed the fewest sex differences were motor and visual networks, which are not association networks. So here, the solid part of the bars represents the proportion of regions that were more represented in females, and the striped part is the proportion of regions that was more represented in males. So the ventral attention network, for example, was bigger in females. And we can see which regions are contributing to this effect by rendering these results on a brain. And so this is the result here for the same ventral attention network that you see in this graph. And here, regions in red are areas that were more likely to be part of the network in females, and regions in blue and green are areas that are more likely to be part of the network in males. And similar to what we see over here, you see much more red, indicating that the ventral attention network is larger in females. And when we looked at the results this way for this default mode network that showed the greatest sex differences, we noticed something really interesting. So it turns out that these areas that have the largest sex differences belong to different association networks in males and females. So for example, this part of the precuneus was part of the default mode network in females, but part of the frontoparietal network in males. And this part of the temporoparietal junction was part of the default mode network in females, but belonged to the frontoparietal network in males. And I've just highlighted a couple of examples here, but we ended up seeing this type of pattern in other areas that had the greatest sex differences as well. And so what we can take away from this result is that it looks like these areas that show the greatest sex differences in topography function as part of different association networks in males and females. So next, we wanted to see if we could classify if an individual is male or female using their topography. And to do this, we used a machine learning technique called support vector machine. And this technique first tries to find the best way to separate two groups of data, and then uses the algorithm it comes up with to classify new data into one of those two groups. So let's say this red group is girls and this blue group is boys, and we give the SVM model brain information and tell it who is male and who is female. It first learns what's the best way to separate these two groups. And then we give it the brain information for a new set of subjects, and it uses the algorithm it learned from the first group to classify the new subjects as male or female. And with this method, we were able to use a subject's topography to classify whether they were male or female with 83% accuracy. And this image shows us the weights from the model added up across all the networks, and regions in yellow were more important in classifying subjects, while regions in black were less important. And after characterizing the effect of sex on topography, we wanted to relate the sex differences in topography we saw to gene expression. So we correlated the weights we got from our machine learning model, basically this map over here, with gene expression from the Allen Human Brain Atlas. And the Allen is a publicly available data set of gene expression. And to get this atlas, they took the postmortem brains of 6 donors and then sampled them repeatedly to get gene expression from more than 20,000 genes across the brain. And we use this atlas because it has really good coverage of gene expression, and because it's one of the most commonly used atlases, gene expression atlases in the field. And what we found is that the regions that were most important in classifying subject sex were enriched in genes expressed on the X chromosome. So this plot shows the result of our enrichment analysis. And what we have on the y-axis is each of the chromosomes. And on the x-axis, we have the level of enrichment, which is just a representation of how correlated genes on that chromosome were with our imaging results. So being further to the right means that expression of genes on that chromosome were more correlated with the sex differences we see in our imaging data. And the solid bars here represent significance. And so what we see is that sex differences in topography were most correlated with X chromosome genes and that this enrichment was significant. In contrast, the sex differences in topography were anticorrelated with expression of genes on Y, though this finding was a trend. We also found that regions showing sex differences in topography correlated with genes expressed in excitatory neurons. And this plot shows the results of our cell type specific enrichment analysis. And what we have here, again, on the y-axis is the different cell types. On the x-axis, we have the level of enrichment. And so what we see is that the regions showing sex differences in topography correlated with genes expressed in excitatory neurons, which are these bars in blue. And I think this finding is really exciting because it corresponds pretty well with what we know from the preclinical literature about the effects of estrogen on excitatory neurons and glutamatergic dendritic spines. And in the context of that literature, this result, while preliminary, suggests that one potential mechanism by which sex differences in topography may arise is through the organizational effects of sex hormones on cytoarchitecture. And one thing I want to point out is the results that I just presented regarding sex differences in topography, the X enrichment, and the cell type enrichment, we've now replicated across 3 independent data sets. Haven't presented the results here, but it is in a preprint. So to summarize what we know so far, we know that pregnancy is a time of heightened vulnerability to depression and that the brain changes during the perinatal period. We also know that there is individual variation in the spatial layout of brain networks that relate to depression. And we know that the areas that are most implicated by pregnancy overlap with networks that are implicated in depression. And we also just saw that sex differences in topography of these networks are related to differences in gene expression of cell types that are known to be influenced by estrogen. But what we don't know is how pregnancy-related brain changes relate to the emergence of depression during the perinatal period. And we also don't know who will go on to develop perinatal depression. And which are the questions that we are hoping to answer in one of our ongoing projects that uses multimodal neuroimaging to understand perinatal depression with a particular focus on person-specific functional networks as potential indicators of perinatal depression risk. So the overarching goal of this line of work is to eventually develop quantitative predictors of risk for perinatal depression, as well as better understand the mechanisms underlying the emergence of depression during the perinatal period, so that way we can improve interventions that limit overall exposures. And to do this, we're recruiting women who are planning to conceive and then following them from preconception through pregnancy and the postpartum. So we recruit women who are planning to conceive and then assess them in the follicular and luteal phases of their menstrual cycle with clinical assessments, neurocognitive testing, blood and saliva collection, and 3T MRIs, and then follow them throughout pregnancy and the early postpartum with these same measures. And then we continue to assess them with remote ratings for 1 year postpartum. And then a subset of participants also undergo 7T MRIs both before and after pregnancy. And I'll talk more about this in a minute, but we're choosing to assess them in both the follicular and luteal phases of their menstrual cycle because we think that the delta between these 2 time points is what's going to be most informative in predicting future risk of perinatal depression. And we're choosing to continue to assess them for 1 year postpartum to capture the time windows during which most women will have weaned breastfeeding, which, as we know from clinical experience, is a time of vulnerability for worsening of depressive symptoms, likely in part because of the hormonal fluctuations that are going on during that time. And then women who are assessed preconception, but who don't conceive within 9 months are then invited back to redo the initial assessments and serve as a sort of longitudinal control arm. In terms of the measures that we'll be collecting, participants will fill out questionnaires that assess a variety of domains, including depression, anxiety, cognition, sleep, stress, psychosis. While we're focusing the main aims of the project on depression first, we also want to include these scales to assess other symptoms to expand later, and also because of the comorbidity. So because these questionnaires generally focus on a given domain, we're also using a semi-structured clinical assessment that will allow us to better account for comorbidity amongst diagnoses and subthreshold symptoms. Participants will also complete a neurocognitive battery that will help us look at how brain changes during pregnancy relate to cognition and executive function changes across pregnancy. We also collect blood and saliva samples, and we have permission to access participants' electronic medical record, which helps, and this helps us assess if there are major changes in either clinical status or symptoms between study visits, and also allows us to keep track of symptoms between study visits without overburdening participants with study-specific related tasks. And then in terms of neuroimaging, at 3T, we'll get a T1, which will let us look at gray matter structure like volumetrics or cortical thickness. We'll get fMRI, where we can look at many metrics, including personalized networks, a diffusion scan, which evaluates white matter microstructure, arterial spin labeling, which measures cerebral blood flow. And then at 7T, we'll be getting another T1, as well as glucest, which measures brain glutamate, and spectroscopy to measure GABA. And these will allow us to evaluate the impact of pregnancy on relationships between neurotransmitters and then brain function. And inclusion criteria for this study include females between the ages of 25 to 40 who are trying to conceive or planning to start trying within the next 3 months and have no prior pregnancies beyond 12 weeks. And if they're participating in the luteal component, also have to have regular menstrual cycles. And one unique aspect of this sample is that we're enriching for women who are at risk of perinatal depression. So women who have a history of mood symptoms related to hormonal fluctuations, including premenstrual dysphoric disorder, premenstrual exacerbation of an underlying mood disorder, mood sensitivity to contraception or fertility treatments, or family history of perinatal depression. And while there are many biological and psychosocial risk factors for perinatal depression that we certainly hope to explore in future phases of this study with a much larger sample, here we're defining the risk factor of interest as a history of mood sensitivity to these hormonal fluctuations, because perinatal depression is clinically pretty heterogeneous, and patients who come in with these risk factors seem to look a little bit different in terms of their symptoms in response to medication, and also because of a particular hypothesis that we're interested in testing, which I am excited to tell you about. So the overall goals of this line of work are to identify preconception predictors of perinatal decompensation and to identify brain changes associated with the emergence of depression during the perinatal period. So regarding preconception predictors, we think what's going to be the most predictive of who goes on to develop perinatal depression will be the difference in connectivity of personalized default mode networks between follicular and luteal phases. So just to unpack that a little bit, the default mode network is that network we talked about that's involved in internal and self-referential thinking and has been implicated in the pathogenesis of unipolar depression, and is also that network that the regions that change the most structurally during pregnancy usually belong to. And so basically, we think that across the menstrual cycle, there are these hormonal fluctuations that cause changes in how this network functions that may or may not contribute to subthreshold symptoms. For example, in patients with PMDD, a premenstrual dysphoric disorder, or patients who have some premenstrual mood symptoms but don't really meet criteria for PMDD. But that in these patients, this delta in brain function becomes magnified during pregnancy with the greater magnitude of hormonal shifts. And then regarding charting brain changes associated with perinatal depression, we think that emergence of depression during the perinatal period will likely be associated with greater reorganization of association networks. And I should mention that while I mentioned the default mode network here, we are, of course, also looking at all of the association networks. So this is a fairly unique study, given both the methods and target population. So there were definitely some challenges that arose as we were designing it that ended up being pretty cool opportunities for innovation. And I just wanted to share a couple of the most significant ones. So we knew from the outset that we were designing this study around the best way to study personalized networks. But one challenge that arose here is that we know from existing literature that using the traditional fMRI sequences, we would need to collect a lot of fMRI data in each session to derive stable, reliable PFNs. But doing extended duration scans was going to be an issue at multiple points in our study, not only because we need a lot of data, but we also need it to be good quality data and low motion data, which is probably going to be an issue if a pregnant participant is being asked to lie on their back later in pregnancy or stay still for really long durations of time. But this ended up being a really great opportunity to do multi-echo fMRI. So just briefly, the majority of fMRI data that the field has acquired so far has been single echo. And basically how that works is scanner emits an RF pulse, and then we wait until the time where we think that it's going to be getting the peak signal, and then that's where we record data. So you're basically collecting one image per pulse. And then in multi-echo, you have a pulse, and then you collect data both at that peak time, but then also these like non-peak times. So you're collecting multiple images per pulse. And then this additional data improves signal to noise ratio, among other things, and makes it so that with multi-echo, you can get the same quality personalized networks you can get with single echo, but with much shorter acquisition. So this was great and really exciting, but it ended up presenting a new challenge. And that challenge is that the multi-echo sequences that we wanted to use triggered a warning for high peripheral nerve stimulation, and peripheral nerve stimulation, it's basically stimulation of peripheral nerves and can be like a tingling sensation that some people experience during MRIs, which is usually fine and benign. But during pregnancy, limiting this peripheral nerve stimulation helps to ensure that the fetus isn't being inadvertently stimulated by the MRI gradients. And there aren't any known harms from using the peripheral nerve stimulation settings that are used in clinical imaging, so this may not really be a consideration elsewhere, but it's one of the requirements for research MRIs in pregnancy at Penn, so it was something we were considering. So we thought that this was going to be a major hurdle, but it actually ended up being totally fine. Some of the things we learned in addressing this are that this seems to be primarily determined by the sequence parameters, and that really just slight changes in these parameters, basically that involve increasing the duration of time between the readouts and also dropping the last readout. That allowed us to reduce the peripheral nerve stimulation levels to safe levels, and we still get really good data. So one other challenge and opportunity I wanted to bring up was positioning during MRIs, because this was actually the most significant challenge in designing this study. So when I was a med student, I had a patient who needed an MRI, and I remember my attending made a major teaching point that this patient would have to be imaged on her side. And then I assumed that this was the case for all MRIs in pregnancy, and it was really not until we started planning this project that I realized that this actually hadn't been worked out for neuroimaging yet. So what's the issue with imaging supine or lying on your back during pregnancy, the way we do for all neuroimaging? Well, subjectively, many women may find this uncomfortable for extended durations, particularly later in pregnancy. And if they're uncomfortable, they're more likely to move, which can affect data quality. And then the reason that it's avoided clinically when possible is because of potential compression of the inferior vena cava, which is this blue blood vessel. And so that basically later in gestation, if a woman is lying supine, the gravity uterus can compress the inferior vena cava, which is the blood vessel that brings blood back to the heart. Can also impact delivery to the blood delivery to the placenta. And so you can easily relieve this compression by turning on your side. And part of the reason that we wanted to avoid inferior vena cava compression is because of the decreased blood flow back to the heart and potentially placenta. And so, for example, here you can see the amount of blood flow that is pumped out of the heart in the supine position, which is in red, versus the lateral position, which is in blue. And you can see that this is pretty affected when someone is lying on their back versus their side. There's about a 30% decrease in cardiac output if someone's on their back. And most women are able to tolerate this totally fine for short durations of time, don't experience any symptoms because of compensatory mechanisms that maintain perfusion. but it's not totally clear if this compensation is 100% or if there's subsymptomatic changes that are impacting the bold signal. And then regardless of impacts on bold, another major reason we were hesitant to proceed with fully supine imaging was because of this particular study population. So here we're recruiting women who are at risk of perinatal depression. And if you'll remember, about 2/3 of women with perinatal depression also have a comorbid anxiety disorder. And while the medical consensus has changed in recent years that lying on your back during pregnancy is not unsafe for short periods of time, there are still conflicting procedures that can make it confusing for patients, and it's not uncommon for patients to receive outdated information, so we really didn't want this to be a barrier or something that participants were anxious about. So we considered a few options. If we don't want to image completely supine, easiest thing to do would be to do what we do for most clinical procedures, which is just place a pillow to prop up one hip. The issue here is that when the head and neck aren't fully aligned, you may get lateralizing effects on bold that are a result of the neck being slightly turned. Another position we considered was the left lateral decubitus position, or lying fully on your left side. And I really wanted to make this one work because it seemed like this is what would be the most comfortable position for someone who's pregnant. And if they're comfortable, it probably means that they're going to be moving less during the scan, which is really important. It's also the position that's used for clinical MRIs of other areas that aren't the head. So for example, if someone was getting an MRI of their knee. Unfortunately, this didn't work out for several reasons. And one is that the usual head coils, size of the head coils, there isn't really enough room to be in the lateral diameter to be looking fully to the side. And unlike other receivers, the head coil for neuroimaging is fixed, and so it can't be turned. And while we did consider dropping down to a lower resolution coil with more room that's used in clinical imaging, but even if we were able to do that and acquire the data, most of the validated pre-processing pipelines wouldn't be able to work with this data. So we finally settled on a position that I'm actually pretty happy with. And inspired by clinical protocols in pregnant women that require keeping the head and neck aligned, we decided to image in the 30-degree left lateral tilt position with the head and body aligned. And this fully relieves inferior vena cava compression. It fits in the 32-channel head coil, and it works with the pre-processing pipelines. So our protocol is basically positioning participants, pregnant participants, is to have them lie fully on their side for the 90 degrees left lateral decubitus position for 90 seconds, and then basically turn onto a wedge, which keeps them in the left lateral tilt position. And this is the procedure that most displaces the uterus off the vena cava. So we just started recruitment, so results TBD, but hopefully we'll get back to you soon. But I want to close by revisiting our clinical case. So just to briefly summarize, our patient is a 35-year-old who's planning to conceive, but on 2 medications, one of which has limited reproductive safety data. And she comes to see us for guidance on whether she should continue her medications during pregnancy. Right now, the way we'd approach this would be to get additional information to try to figure out what her diagnoses are, or diagnostic clarity. We would weigh the risks of continuing these medications versus the risks of untreated depression, and then make an overall recommendation based on our assessment of how likely she is to decompensate. This is usually fine, but we really can't be sure of her chances of developing perinatal depression because we don't really have any quantitative markers. And while this is many, many, many steps away, you can envision that if personalized networks are found to reliably reflect future risk of perinatal depression, patients could potentially undergo precision functional mapping as part of preconception counseling evaluations. And then this information could be used to inform the odds or likelihood of someone developing depression during pregnancy and the postpartum, and then enter into this risk-risk discussion of how we can counsel patients. And then this would help limit medication exposure when the likelihood of developing depression is low, and then also help prevent additional exposure of symptoms when the odds of developing depression are high. But what about in patients who have high odds of decompensating and are on a medication with unfavorable safety data? Well, we think personalized networks might be really helpful here too, because with current targeting measures, only about like maximum 50% of patients experience remission with TMS, but by using a person's specific functional architecture to inform targeting, we'll likely be able to increase those odds that someone responds, which may make TMS a reasonable alternative for management of perinatal depression. But also just want to take a second to acknowledge the amazing team that I'm so lucky to be a part of and learn from, and also acknowledge my funding sources. And thanks so much, everyone, for listening to my talk, and I'm happy to take any questions if anyone has any.
That was incredible, Sheila. I've said this to you, but it's worth saying publicly. I just think you are at the forefront of this emerging field, and your unique expertise spanning reproductive psychiatry from the clinical standpoint and being like among the best of the best within the imaging community is just such a rare, grouping of talent. So on behalf of women everywhere, I'm just so happy that you're pushing these questions forward. But to get to the questions, because they're popping up, Rebecca asks, in your opinion, are structural or functional phenotypes better predictors of perinatal mood disorders?
So I don't think that we have the data to actually answer that question, but from some of the work not related to perinatal depression. I can't remember if it was the BWAS paper or one related to it, but it showed that the functional measures were better predictors than structural measures. And so likely we're thinking we'll likely see something here. But of course, as we're going forward, we want to delineate what are the impacts of perinatal depression on functional measures, structural measures, neurochemical measures, and see how all of these interact in predicting perinatal depression.
It's going to be the beauty of this data set. You're getting it all, so you can really dig into it. Natalie asks, thank you for a fascinating talk. I study dysmenorrhea and the development of chronic pelvic pain and have a more technical question. How many subjects and how many repeated scans are ideal for determining person-specific networks?
How many scans and how many subjects? Okay, so within one subject, there is not necessarily a right answer, but I'm going to answer within one subject. It probably depends on if you're going to use single echo or multi-echo. If you're using single echo, it's going to be pretty long. There was a paper, I think Timothy Lauman was the first author, where they show this curve that like at 27-ish minutes, you get like 92% correlation of what you would of like ground truth. So you could go at the 27 minutes. Other papers have shown 40 minutes more accurate. But more recent papers have shown that you need like a couple hours of data to get closer to the ground truth. So it just keeps getting more complicated. For multi-echo, however, we can expect it to be significantly shorter. However, we don't have a great answer on what that exact time point is yet, because it is pretty new and hasn't necessarily been delineated in the same way. But even within multi-echo, it's going to depend on a lot of things, like the specific sequence parameters that you're getting. How many echoes are you dropping to get below peripheral nerve stimulation warnings? And then processing is a lot of it too. Like, was your subject moving a lot in the scanner? You're probably going to need a lot more data. What type of processing pipelines are you using, and how are you accounting for motion and denoising and all of that? So many things. But the bottom line is the more you can get, the better.
I do have a quick question myself, actually. How did you decide did you randomize which way to put the person in the scanner?
In terms of lateral tilt? We went with left lateral tilt because when you're on your left side, that's the like maximum displacement of the uterus off of the IVC. Whereas when on your right side, you can still have some compression. But of course, it's better than supine. So we just went with left because like that's the.
Do you think there will still be some lateralization issues there with the left?
I think if there are lateralization issues, it would be from like head and body not being completely aligned. I think this study is the first one that's doing this, so I guess we're going to have to
exactly. I guess we'll see.
But we're also collecting some data in non-pregnant participants like supine, and then at the 30 degrees to compare them and see how things. we've just basically done it in just my CRC and looked at things. And those look fine, but now
Now those go, yeah.
I have also a quick question about the study design. You were mentioning you will collect both 3 Tesla and 7 Tesla. Would you like to recruit like these 2 different Teslas to compare, or do you have any like rationale about why do you choose between them?
So I want to get 3T data because we can get it during pregnancy, which we can't do with 7T data right now. But I also want to get 7T data because I'm really interested in glutamate. And this is totally speculation. So if someone watches this video like 5 years from now, they could be like, man, she was totally wrong. But there's a ton of excitement about allopregnanolone and GABA in perinatal depression with things like brexanolone, zuranolone. There's really not that much about glutamate. But we do know that there are a ton of interactions between estradiol and glutamate, some preliminary interactions between allopregnanolone and glutamate. And part of the reason I'm interested in glutamate is because if we show that it is somehow involved in the pathogenesis of perinatal depression, it wouldn't necessarily involve going off and developing a new drug. Like there are many drugs for major depressive disorder that could be easily repurposed to target perinatal depressive symptoms, some of which are safe in like lactation. So could be really great to try to repurpose those if we find something here.
Perfect, thank you.
I think maybe we have time for one more, although so many people have questions. So if I may, I'll just have them direct them directly to you, Sheila, because I know this is going to start so many cool conversations. But we have one question from a researcher from Mayo Clinic in Rochester, also working on women's health, and has a spectroscopy methods question. They say, what is the method that you're planning to use for GABA quantification at 3T? Maybe if you want to dig into that just a little bit more.
We are not planning to do GABA at 3T. We're not doing any spectroscopy at 3T, primarily because the results are not that great. We're just doing 7T. We're primarily interested in glucest, and we're basically just getting like 1 voxel of GABA to show a little bit of comparison to, 1 voxel of GABA to show some data that's more similar to what's already existing. But we're spending the majority of the scan acquiring glutamate.
Fantastic. And maybe we can squeeze in the last one. So Natalie follows up and says, are your participants looking at a crosshair for the resting state? What are your thoughts on using naturalistic stimuli like movies to limit motion and identify networks?
Oh my God, that is such a great question. And it was one of the challenges and opportunities that I didn't have time to present here. But we actually spent a lot of time trying to get movie watching up and running. And we actually already selected the movies, edited them, tested them. And then we decided to drop it at the last minute because for 2 reasons. One, we added more time points. And so there was a lot of repeated measures, and there's not a ton of data on how repeated measures are going to be impacting response to movie watching. But there, I think, was one paper that said the emotional response could be different. Also wasn't really sure how to integrate using like different movies, different stimuli. And part of it is that I also wanted to figure out the left lateral tilt imaging, which they won't be able to really see the screen. So they're not really going to be looking at a crosshair or movie watching. And so it was kind of deciding between the two, which one did we want to do more? And I felt like if we went with movie watching, we would be introducing known confounders of like either lateralizing or like IVC compression. But I mean, I think it's super cool, super exciting. Would love to in the future have like an additional time of movie watching, especially preconception. That's what I was really excited about. But unfortunately, like you have to make choices. It's the amount of time and budget you have. So
for your next big grant in question. Well, on behalf of everybody, please join me in thanking Dr. Shanmugan, and keep your eye on her because she's going to be leading this field for the next 20 years, and it's going to be such a pleasure to have a front row seat to that. So thank you, everybody, and we'll see you again next month.
Thank you so much for all the
Thank you so much.
Great talk. For having me. Thank you.
Have a great talk. Thanks so much.
Bye, everybody.
Bye-bye.